Okay, so this is going to be the closing session for the 2013 Rare Neuro-Immunologic Disorders Symposium. Hard to believe. I think we're going to wait on a couple more people who are coming down. So for those of you who were here yesterday, you'll remember the ground rules and the caveats. Dr. Schreiner did a much better job than I will do. A few things. Everybody comes with a different set of specific histories. Feel free if there's a question you have, but recognize that we do not get your full history. We do not have a full understanding. The comments we make up here are not meant to be specific medical advice. Every specific decision you make should be done in the context of discussion with your treating physician because there are often details lost that are important. So just keep that in mind. Even though the topics for today have been on the regeneration and repair side, and a lot of what we think the conversation will be on the science of that. Obviously, if there are burning questions relative to other issues, feel free to ask. And with that in mind, we have some written questions, but I'll go ahead and open it up to the floor first. If you'll just raise your hand, there are Dina and Stephanie with microphones. We're going to try and wait till they get to you with a mic to start asking. So first question will be in the back row in the blue.
I know we've read on the internet in various places there are some places in the world that are actually doing stem cell. Could y'all offer up where those are and how successful they've been if you've been able to determine that?
Okay, so besides the 7-Eleven on Harry Hines and Stem, just go in the back, knock 3 times, tell them Mike sent you. Mike, you want to go first?
So let me start off by saying there's a great website called clinicaltrials.gov. And if you go there and you just type in something like myelin stem cells, you'll get dozens and dozens of clinical trial sites all over the world. And many of them are very legitimate institutions doing really good research. If you decide to go to one of these places, I would encourage you to think about it, contact us, have us evaluate it. It may be worth your time, you may be a good candidate, and it may be helpful for you. What I would encourage you, or what I discourage you to do, is go to a purported stem cell institute, a private clinic, that for $15,000 to $30,000 will take out your mesenchymal stem cells, purify them in the dish, and give them back to you in various forms. We don't know how these work. We don't know if they work. We don't know exactly what their protocol is. People ask me that all the time. I'd say if the protocol is not harmful and it's at a beautiful location, go and enjoy a vacation. And if you happen to get some stem cells in a non-harmful protocol, fine. You know, if it really won't hurt you. They take something from your own blood and put it right back. Yeah, you're paying $15,000, but it's hopefully not going to hurt you. So that's basically my advice: is be very careful about stem cell institutions that make you all these grand promises. But it's not really based on the hard science.
Barbara or George, I don't know if either of you have a comment on what's been out there relative to these clinics.
I can tell you not to go to China. China has had a number of attempts at doing stem cells for like spinal cord injury, and they've done several hundred patients, of which none of them have shown effective recovery. So the problem is, as was alluded to earlier, is that many times when they transplant these cells, they're not well characterized. So you're not really sure what you're receiving, and they're not well controlled. So it's very difficult to know exactly what your outcome is going to be next compared to anybody else who receives those cells. If they're not well characterized, and you're not really sure what you're getting, and that could be problematic. So you want to make sure you go, if you know, to a place that's has a good reputation.
And I'll add just 2 comments to that, and then I'm curious if Carlos wants to chime in as well. The 2 comments I add is for a couple of patients I know who have gone overseas for stem cells and have said, it's helped, I'm doing much better, and they come back. I said, well, what did they do? They gave me a stem cell transplant. I said, well, anything else? Well, there were 5 days of steroids, so I didn't reject the cells. And then every day for 6 weeks, I was on the beach with their therapist, and I felt so good, and I was working out. I was like, well, hell, if you'll give me 6 weeks every day with Karen McCain or Kathy Zakowski or, you know, any of our folks, I'm going to get you feeling a lot better. it's not on the beach, it's in Dallas. But so you always have to wonder what else goes on. And the second is there are a lot of international clinics and no oversight, literally no oversight. There was a Costa Rican clinic for many years that offered therapies. It was shut down by the Costa Rican government. I take that as an independent bad sign. The next week, it was open in Panama. So the Panama City clinic was the Costa Rican group, and they moved to Panama City. So there's a lot going on out there that we just do not have any knowledge about the reputation or what happens behind the curtain. So I agree with being cautious. Carlos, do you want to?
In medicine and healthcare, we always work with the principle, do no harm. And I think that, unfortunately, in the 21st century, medicine has been contaminated with a very annoying virus, is profit. And medicine has been contaminated by business. And unfortunately, what we see in other countries, and even here, is the business of medicine. And I think that from ethical point of view and from medical point of view, it's really difficult to understand what other people are doing with the stem cells and trying to promote things that haven't been proven. And I think that the beauty of things that we have in the United States is we hate control, but fortunately we have control for everything has been done in medical management. And clinical trials are overseen by the government, are overseen by unbiased network of people that really define if the outcome is real or not real. So that's the reason we need to be extremely careful with the different approaches in terms of treatment.
I think I just wanted to say, this kind of goes back to the critical thinking that I had brought up when I spoke. So if it sounds too good to be true, then you should be really critical of it. I'm not saying don't disregard it, but think about it. Talk to people that might know more, and that will help you make a better decision.
On the science side for Barbara, based on what you presented, just scientifically, do we think that the random infusion of mesenchymal stem cells will lead to dramatic functional recoveries, or is it going to take more than just the exposure of the cells to the person? I mean, do you have a sense of that?
It's definitely going to take more than the exposure of a person to the cells. When I mean the infusion, it is, and the beneficial effects have been mostly done in animal models, and I think we are still ways of different trials before we can feel comfortable saying that this may also work to the same degree in human and moreover into specific applications in human, because it has to be very specific, obviously.
Okay. Okay, next question. And if, okay, over here.
Earlier you talked about numbers. Why are diagnosing neurologists not required to report their diagnoses of TM to the CDC or someone?
Do you want to jump in, Carl?
I forgot exactly what CDC means. It's communicable disease.
The Center for
Disease Control.
and Prevention.
So the CDC philosophy is just track down infectious disorders mostly, or preventable disorders, not only infections, but other disorders in general. Unfortunately, transient myelitis has been orphan disease. If it's not for the TM association, nobody would be paying attention to TM. And the reality is only until 20 years when people start blogging around TM, this is a disorder has been recognized. And it's a shame to mention this, but there are even neurologists that don't understand what is TM and don't recognize what is TM. So I think that in the future, probably we will have a much better options for reporting this disease. One of the priorities that we have with the TM Association is to establish registry. With registries of patients with myelopathies and myelitis, we will have a better opportunity to tell the government, well, this is really a major problem. This is a really a a neurological problem that is producing a major impact in the population. So I think that unfortunately, we need to generate that need. The government or the institutions that oversee the health problems in the United States are not going to take the lead. So we need to be very proactive, and that's the reason being part of the TMA is critical. Be proactive in spreading the word about transient myelitis or myelopathy in general is very important.
Okay. If you have a question, raise your hand. The mic will come to you. While we're waiting for that, I'm going to go ahead and use one of the questions that were submitted. So this is an interesting one. I've actually had it in clinic episodically. The question was written as, since myelin is predominantly lipid, is there any concern with any of the statin drugs when trying to recover? Mike, you want to?
I'll take a stab at this one. There was a big trial a few years ago looking at Lipitor as a beneficial treatment for MS, and it was thought that it could really help sort of anti-inflammatory, and then it turned out to be a little bit harmful. So the question is not unnecessary. It is an important question. I don't think it's as direct as something like a statin changing the amount of lipids you have for recovery. I think it's more complicated than that. The brain generally and the spinal cord takes what it needs. So if you have any lipid in your body, usually the brain will take what it needs. If any energy, the brain will get it first. So I don't think it's a concern of capacity of lipids for recovery. I think it's going to be more complicated than that.
Okay. Second row.
So with the comment that was made about the neurologists not being educated or informed about transverse myelitis or NMO, is there anything that's being done, like through the TMA or through the Guthrie-Jackson Foundation or something like that, that is trying to educate the neurologists around the country so that people are more familiar?
The answer is yes, but we are in the very early stages of that education. In the past, different institutions and the Transient Myelitis Association have been promoting this type of symposium. And the fact that we have a very good network of information through the websites is facilitating that many physicians around the country are able to establish contact with people around UT Southwestern, Hopkins, and different institutions in which there is more expertise. But again, this is an early stage. Probably when you go to your neurologist and you feel that your neurologist is not necessarily very aware about the TM, just mention Transient Myelitis Association, mention the websites at UT Southwestern, at Hopkins, and I'm very sure that some of them are going to establish contact with us. Remember, the doors are always open. If you contact our Transient Myelitis Center, there is always somebody there available for interaction via email, phone, and the same happened here in Dallas with the UT Southwestern Center. The same happened with the TMA Association. So I think that the fortunate situation is that with the media now, with the availability of all of this network of communication, we are improving that education as well. But there is a lot of things that need to be done.
And I'll add just two quick comments to that. One is, and if Sandy were here, he'd be raising his hand saying, I want to make a comment on this. You don't need a TM expert to be your local physician. You need a physician who's willing to reach out and take advantage of resources. We are not going to get a TM expert in every city across the country. It's not going to happen. We'd love for it to happen, not going to happen. What you need are people who are open-minded and willing to collaborate with people who spend more time on this, so that if they're picking up the phone and talking to Carlos or Mike or myself or Audrey or Maureen or any of the staff at the institutions, we can give advice and help without you having to be established somewhere. That tends to have to be provider to provider for legal reasons and otherwise, but it's a very efficient way to try and increase the amount of resources and education you have in the physicians and healthcare providers that you're working with. The second short comment I will make is around the education side of things. There is an effort to increase the number of TM, NMO, ADEM conscious physicians, and I think the fellowship, the Jim Lubin Fellowship, is a great example of that. as Alan goes off and establishes places, as we've gotten our hooks into Dr. Horton here and tried to bring her in, the more folks who go through this spread out, there's an interesting phenomenon that happens. When I first came to Children's in Dallas and consulted for the first time on a child with transverse myelitis, severe case, and said, well, why don't we do plasma exchange? The Children's looked at me like I had grown a second head. They said, well, we'll do this, this, and this first. I'm like, no, come on, give it a try. Let's all go. Let's do it. And so for months, we kept doing this, and the residents started seeing the results. They started seeing kids come back to clinic walking and doing much better than they had experienced before. About 9 months into being here, a few months go by, and I hadn't seen a single kid at Children's. I hadn't been paged to go over, and I said, well, that's weird. That's really odd. And I go to clinic one day, and there's a new patient there who had been in the hospital 8 weeks earlier and gotten fully treated with plasma exchange and the whole 9 yards. The culture changed to be very different. Now they just assume it's standard of care. And we had our first resident who had been training here who left, who I ran into a conference. He says, well, you didn't tell me we're the only ones doing this. Because he went to his new hospital, and the first kid he saw, he's not a Neuro-Immunology, he's doing epilepsy or something else, but he was on service and saw a kid with one of these conditions and said, let's do plasma exchange. And they looked at him like, what the hell are you talking about? And I was like, finally, somebody else has to deal with this. So slowly but surely, as we go, it's a slow process, but there are ways that the TMA has been supporting the efforts to kind of infiltrate around the country. In the meantime, getting your physicians to collaborate is helpful. So,
and your therapists and occupational
yes.
therapists, as Kathy mentioned yesterday, they are probably a very valuable part of the team. And I think that if the therapist is not able to understand what is TM, there are a lot of people around here that will be providing information and guidance.
Okay. Here we go. Yep.
In Dr. Levy's presentation earlier, you said that in transverse myelitis, there's only one lesion in that. In my case, I have lower problems as well as upper weakness in the arms, and range of motion in the arms is not what it should be. I wonder, I thought I had more than one lesion, but maybe not. But how common is it for the folks here or people you see to have upper body problems as well as lower body?
Well, when we profiled our TM patients over a decade, we found that about half of them had lesions in the top half of the spine and half of them had lesions in the bottom half of the spine, with really no prediction if you were older or if you were female or male, where your lesion would be. So if your lesion is in the top part of the spine, it could affect anything below, your arms, your legs, bowel, or bladder. If it's in the middle part of the spine or below, it probably won't affect your arms. And it's probably about a 50-50 split.
So throughout the day, you mentioned 2 different antibody strategies that are obviously pretty effective since they've made it to clinical trials. So they both work through different mechanisms. Has it ever, eventually if these make it through clinical trials, will you be able to combine both of these things, and will it actually be more effective?
Thanks. Yes, so the answer is possibly. It's whenever we have drugs that operate under different mechanisms of action that both have success, I think the logic is trying a combination in the future is helpful. It's surprising how often that doesn't turn out to be the case and how often we discover problems with an interaction biologically. So it would probably be its own distinct study when that occurs. I'm curious from Dr. Smith, especially based on the research he presented, is we're looking more and more at the biology of neurite growth and remyelination using monoclonal antibodies to try and alter signals. Do you think that's going to be the long-term strategy? And I should preface this for the audience. There are lots of ways to alter biology. So one is an antibody, which is a protein that binds to a target and then either blocks its function and interferes with a network or sometimes upregulates it. And then there are what are called small molecules, little drugs that get in and change the way these things are expressed or activate. And for a long time, I thought monoclonal antibodies would be a bad way to go because they don't get into the central nervous system as well, but yet the first 2 drugs that are coming are those from your research and the knowledge of the field, are there other things in the wings that you think have just as good or better potential for augmenting this biology, the regeneration and the growth?
Well, first of all, the reason they probably got in is because there's probably a breach in the blood-brain barrier at the location of the lesion site, and that's going to allow permeability into that site of larger molecules. We have one of our faculty members in our group is using small peptide antagonists to knock down like P10 and regulate some of the growth pathways. And you can actually trick those small peptides to be permeable to both blood-brain barrier and cell membrane by putting on little tags that allow them to go through hydrophobic domains. And so small peptides have a higher probability of penetrating through areas where you do not have blood-brain barrier breaches. So they would probably be more efficacious in the long run, especially during the late stages of healing when the blood-brain barrier is beginning to reform. I think the main reason the monoclonal antibodies have shown some efficacy is that the lesion is still open and you still have a permeable blood-brain barrier.
Okay. Who has the microphone next? Louisa.
My question's in two parts. One is that I've always heard that recurrent TM is very rare, and yet I have, and I hear from a lot of other people, that ongoing, what I suppose I'd call residual symptoms, where in fact the symptoms were worse than they were in the presenting situation, or in fact some of them are quite new, and involve different parts of the body. So that technically, I'm asking, this is a question, is that still technically not recurrent transverse myelitis, or?
The way I define recurrent transverse myelitis is, like you said, has to be a distinctly different lesion. Or if it's going to be the same area involved, by MRI, I'd want to see that it's inflamed at really distinct times, more than 3 months apart. We use MRI a lot to classify monophasic versus recurrent because symptoms can fluctuate, and you can feel like your pain is getting worse and worse and worse over months with just one lesion because the lesion is still evolving. So it really is an individual case-by-case determination.
How much store do you put in that information and the information that you get out of the results from lumbar punctures?
Lumbar punctures are very helpful to look at active inflammation.
So if you consistently have a lumbar puncture and you consistently have, every time you have one, it shows inflammation.
That's concerning.
Well,
There's still inflammation going. Yeah, lumbar punctures are more sensitive than even an MRI to look for inflammation.
Everyone I've had, it has had active inflammation. It's never settled. And my doctor said to me, there's not much point in doing any more lumbar punctures because we know there's inflammation there. And yet he's not offering me any...
There's still something going on, and if there's still something going on, it should probably be reevaluated and treated. I don't like the idea of persistent inflammation.
I'm sorry.
That equals to me persistent damage.
So there are times that patients need to be very careful with the interpretation of recurrence of transient myelitis. It's very frequent that infections or other factors, environmental factors, trigger exacerbation of symptoms. And that is not necessarily a recurrence of transient myelitis.
Because that causes inflammation
Right,
as well. I understand that, yes,
right,
I do. Yeah.
Right, and it's very important because if there is an infection, there is a phenomenology that people are investigating more and more, is something that's called microbial translocation. Microbial translocation is basically a biological phenomenon in which bacteria that normally stay in our gastrointestinal system or bladder is able to go in the bloodstream because there is a disruption of the barriers in those organs. And that itself may produce an activation of the immune system and produce inflammation that eventually is going to produce exacerbation of neurological problems. That doesn't mean that there is recurrence of transient myelitis. That means that other part of your body is functionally abnormally and the immune system is reacting to that. And by having that systemic immune reaction, the brain or spinal cord is dysfunctional without being affected intrinsically by an active process of myelitis or other inflammatory process. So inflammation and infections are issues that need to be taken seriously and need to be treated opportunely, because otherwise it's going to produce a build-up of more problems.
So along those lines, just to kind of reinforce the point, so you've all experienced it. So how many people here, either who haven't had one of these diseases or before your event, ever had the flu or a really bad respiratory infection with fever? Anyone here? Okay, so for those of you who raised a hand, how many of you, while during the flu, felt like crap? How many of you had body aches, muscle aches, fatigue, cognitively disturbed, wouldn't trust yourself to balance your checkbook, right? So, and you had a normal central nervous system. So systemic events in the body have an impact on how our brains and nervous systems function. And if you come to the table having already had a nervous system event, a transverse myelitis, an ADEM, or neuromyelitis optica, the amount it takes for you to cross that threshold and be symptomatic from something in your body, I think, is being lowered. And so that's why, I may get a small cold and just kind of make it through it and do okay. But when my patient gets a small cold and they're down for the count, we're starting at different levels of reserves, is just another way of endorsing what Carl was just saying. And we have to be very careful about exacerbations, attacks, relapses, all these different terms, and really sorting out what is new damage and what is recurrence of old symptoms. And those are two very different but important things.
Thank you. And I just wanted to extend one more thing. With the presentation on optic neuritis, one of my first presenting symptoms was to do with my eyesight, particularly in my left eye. That came on with all my initial symptoms, and I had blurriness, but I had a swimming effect, and my eyesight was deteriorated significantly over the next few months. It then settled to a degree, and since then I've needed regular glasses and eyesight assistance. Is that a normal part of TM, or would normally you be looking at ON for that as well? Because I never had any tests for vote potentials or any of those sorts of things.
So is your question, is optic neuritis part of?
TM, yeah, can that be part of just a presentation of the TM in?
Not from my understanding. Is that correct? Okay.
Yeah. There are diseases where you can get optic neuritis and transverse myelitis as part of one umbrella disease, like neuromyelitis optica or lupus or multiple sclerosis. That can cause lesions in both areas. But if you have just a myelitis lesion, it should really just affect that level of your spinal cord and below. It really shouldn't affect your eyes the way you're describing. It can cause some other cognitive, those kind of disturbances, but really not the degree of optic dysfunction that you're describing. That sounds like something that should be investigated in your optic nerve.
Mm.
That's probably a good idea.
Or Lindsay. Back.
I'm wondering if any of you all have ever diagnosed a patient with TM prior to an acute episode. And in other words, in the middle of a regular exam, has anyone been able to tell that this was coming? And if so, was the protocols for treatment any different?
Mike did once, but it was after several gin and tonics. And
You've hit on a very critical research question. Are there blood tests that could predict transverse myelitis? Are there genetic risk factors or anything else that can give us a clue when you come in before you're attacked that you are susceptible or that something may be brewing? That would be the luckiest find that I would ever have, and I would be accepting the Nobel Prize. So no, there is no such thing, but that is a futuristic goal.
Along those lines, though, there have been situations where we've had patients who are in the super early stages of things where they already have a symptom, but it's subtle, and those are often missed, not necessarily through anyone's fault, they're just subtle. But for patients who have certain disorders like neuromyelitis optica, where we're concerned about recurrent events and our radar is higher, that's probably as good as we've gotten in terms of getting a phone call. And again, it's usually Audrey or Maureen getting the phone call in our clinics and knowing just by talking to the patient something's up, something's brewing, and jumping on things early. Yes.
Are we on? Yes. I'm Gwen, and I came down on May 2nd with all the symptoms of transverse myelitis within 5 hours, and because I work at University of California Davis Medical Center, I just thought I had a pinched nerve, and I went on in and saw my people. And basically, I knew I had a 12-hour wait, but they were able to diagnose me on like hour 13. And so it was pretty quick diagnosis with lumbar puncture, with MRIs, and then the 5 days of treatment. But the results was I don't have any lesions in my spine or in my brain, but yet I still have all the symptoms for the Pinocchio leg and on the left side, and the burning, the banding, and basically there's I think one or maybe more people here that don't have any lesions either, but we still have similar symptoms. Is any treatment, since there's repair of lesions, but we don't have them, but we have the symptoms, is there anything that is coming down the pike for more the nerve endings?
So what very likely happened in the spinal cord is that fortunately the treatment was rapid and effective, that didn't allow the formation of glial scars, for example, or a significant amount of neuroglial reaction to leave permanent damage on the spinal cord. However, at microscopic level, probably there is still some damage. If you remember, all of the axons probably may have suffered some demyelination. Probably there were some vascular changes, microscopic changes. Probably there was some activation of other cells in the system that are producing this disturbance. Remember, the spinal cord, if you take a look of your finger, that is the diameter of your spinal cord. And in that small amount of tissue, you have millions and millions of wires that are going in different directions. So even with a small amount of inflammation, there is going to be disruption of many of those networks. We don't see those in MRI. The MRI is a very nice technology. We appreciate very well the spinal cord, but we don't have the resolution of a microscopy at microscopy level in that MRI. So it's very possible that there is still networks in the spinal cord that are damaged, that are part of the problem that you have with pain. And if you remember the presentations today and this afternoon, there is a lot of network and many, many fibers that are growing or regrowing in different directions after an injury. So that is probably still going on, and it's going to take months to reconstitute the system.
No, we didn't say that. That's a whole different criteria on whether we say it, but yeah. Stay in the group. No, you have to show your MRI at the door. I'm sorry, no lesion. Okay. All right. So before the next question, I'm not sure where the microphone is now. I can jump in front of Stace. Great.
Okay.
So I'm going to mix it up a little bit. That's fine. So I'm going to switch gears a little bit. Carlos, you were talking about bacterial infections coming from other areas, the gut or the bladder, and there's a lot of discussions that go on about diet and bacteria that live in the gut, and this notion that if you aren't familiar, you've got billions of species of bacteria that live in your gut. They produce proteins that we absorb. In fact, some of them we need to survive, but some of them have impacts on the immune system. One of the questions we got is about that, and if there's any benefit for patients taking a probiotic or changing diet to try and alter either the course of disease or symptoms relative to this issue.
It's a very interesting question, and it's one of the hot topics in medicine at this moment, not only for TM, MS, but for many neurological disorders and many disorders in general. In the past couple of years, and actually it's really new, that we are learning more and more about the role of the GI tract in modulating immunological responses. And What we know now is some attempts to modify the bacterial population in our gastrointestinal tract is very important, and the use of probiotics probably is modifying that. Unfortunately, we need to understand better what is the probiotic approach, because there are many flavors. If you go and Google that, you are going to have dozens of web pages talking about probiotics. But if you go in the right direction and with the right approach, using probiotics is going to provide a healthy GI tract. We know, for example, that abusing antibiotics is a major problem for the gastrointestinal tract, because by abusing antibiotics, we are getting rid of bacteria in our GI tract that are beneficial. So the gastrointestinal tract is populated by bacteria that we need to have there, because they contribute to the metabolism of different things. And interestingly, the association of that population of bacteria with other elements of the immune system in the gastrointestinal tract are modulating systemic immunological reactions, to the point that at this moment, one of the interesting topics in immunology is how our gastrointestinal tract is modulating the immunological response, defending our body from autoimmune disorders or producing a damage. Let me give you an example. There is a current trend of research that suggests that children that were exposed to antibiotics early in life have a most disrupted modulation of the immune system, and that is making them more susceptible to autoimmune disorders like lupus, multiple sclerosis, etc. So the role of probiotics in modulating some beneficial response in immunological disorders is work in progress. It appears that it's beneficial, but I think that we need to understand much better what is the best approach to deal with that.
If I can, I'd like to also mention a very interesting research topic that's caught a lot of attention in the MS world. So a group of scientists found that if these mice ingest a bolus of salt, table salt, that there are some immune cells that are released from the gut that are harmful for diseases like MS and NMO. The idea is that if you take in salt, like let's say when you're sick, you drink chicken soup, you're going to stimulate the immune system, and that's good because you want to destroy the virus. But for people with autoimmune disease, this could be bad. You don't want to stimulate the immune system, and high salt boluses may do just that. And the current research, at least in mice, is a bolus of just 500 milligrams. If you think about it, a bagel has 500 milligrams, or McDonald's French fries certainly have at least 500 milligrams. That could be enough to stimulate those bad immune cells from the gut. So ongoing research, don't take any of this too literally yet. Don't come ask me, what kind of salt restriction should I be on, because we don't know yet, but it is an interesting line of research.
Yeah, the other flavor, Mike, remind me about an interesting issue. Probably some of you have been aware of some therapies with parasites for immunological disorders. So there is an epidemiological view that people in tropical countries, including Colombia, for example, don't have too much multiple sclerosis. And people have been exploring that issue, why this population is really protected for MS. One of the hypotheses is that in tropical countries, people have more exposure to parasites, intestinal parasites. And by getting that exposure to intestinal parasites in early age, the immune system develops a protective system that is going to inhibit the potential for autoimmunity in the body. And there are some trials going on right now for different neurological disorders, trying to immunize people using ova of different parasite species that are not pathogenic to the GI tract, try to modulate the immunological response. Again, that is work in progress, but again, expose the potential of manipulating the gastrointestinal tract in favor of the immunological responses.
but they're the funnest trials to recruit for because you have to tell the patient, drink these worm eggs, and it's like a little orange slushy, and they're these little eggs, and you have to drink it down, and that's the trial. Informed consent is very interesting when we do that. So in the back.
Okay, I have a question about some recent research that just came out on the new aquaporin channel that they found in relation to NMO. What does that mean for diagnosis and treatment? Because obviously I can't read the whole article.
Is that the Aquaporin 1 channel
Yes.
that you saw?
Yes.
There's one group in Greece that found some different aquaporins in the spinal cord that may be involved in the disease. It has yet to be reproduced. I think it's interesting. I think it means that for people who may have recurrent disease but don't test positive for the current NMO antibody test, maybe there are other antibodies we should be looking for, like to Aquaporin 1. But I think that study is still very early in the discovery process.
I have a question about probiotics and the antibiotics you were talking about. What if you take an antibiotic every day for, like, macrodentin for urinary tract infections? What do you do about in that case?
I think that the advice that we heard from our colleagues in gastroenterology is that keep taking the antibiotic because that is going to help you to avoid infection, but take an approach to reconstitute bacteria in your GI tract. So using probiotic associated with antibiotic is beneficial. And we are doing that in the hospital setting as well. So the dietitian in the hospital setting knows that every patient receiving antibiotics need to be treated with probiotics, etc.
Okay. While we're waiting for next question, I'm going to give one of the ones on the card. This is for everybody. And I'm going to expand the question a little bit. Are we predisposed for NMO and TM? Do we have it from the time we are born until it decides to present itself?
I suspect the answer is that everyone has some threshold for developing autoimmune disease. Some may be more likely to develop autoimmune disease, and some may be less likely. And then in that context, you must be exposed to something environmentally that tricks the immune system into that disease. Maybe it's a virus, maybe it's an environmental compound, it's something in the air, something in the water, that tricks the immune system and makes it think that maybe myelin, maybe aquaporin, maybe whatever is supposed to be attacked. So I think it's going to be a combination, and I think we're all predisposed at some levels, again, some more than others. Anybody else want to?
No one wants that one. So we do know we have some genetics data and more coming that indicates that these diseases probably do not have a gene. So this isn't something you pass on to your children or anything along those lines. There are genetic predispositions, as Mike said, to autoimmunity, but there is not a TM gene and probably not an NMO gene, if you will, in the same case that for a disease like Huntington's disease or some Parkinson's patients have a genetic or familial condition. These don't look that way. And the best data we have says it's the perfect storm, the right host getting exposed to the right thing at the right time. So we can all be exposed to the exact same virus, none of us get TM, but if one of us had the right other issues going on, a low vitamin D, an exposure to a different infection the week before, it's really the constellation of things coming together to probably lead to these events. One of the things that's interesting, and if anyone can figure this out, please see me at the end. We know that in NMO, for example, that there are patients who have been documented to have the antibody, this autoimmune profile, for a decade or more with zero symptoms, not a single attack. And then one day they have a clear-cut attack. And so we know that having a confused immune system is necessary but not sufficient to get the symptomatic illness. And so one of the questions is, well, what's the other thing that happens? Their immune system was confused, but did it just not have access to the point that Dr. Smith was making, the blood-brain barrier, or what else was it that led to that immune system actually causing damage? Because it existed for years, potentially, before the day you had the event. So, just thought, I think we're in the middle. Yeah, Elizabeth?
There it is. My question was concerning optic neuritis and recovery specifically, since that's what we've been talking about today. Do you tend to notice a better rate of recovery for one eye versus over the other, or unilateral versus bilateral optic neuritis? I feel like I know a lot of patients that are permanently blind in the left eye specifically, and I don't know why. I was just curious if there happened to be any statistics on that off the top of your head.
So, Lindsay, do you remember in our data set if there was a eye preference, right eye versus left eye? You've looked at the data probably more than anybody.
No, I mean, not from what I recall in our data. I mean, we weren't specifically looking at that, but I don't remember there being one eye versus the other that would necessarily get better. I mean, we didn't specifically look at that, but I didn't notice any trend. No, it really just depends on, we analyze each eye separately, independently of each other. So it doesn't really, they don't depend on each other. It just is how damaged each one is on its own.
There is, and I don't know if you've seen this in Baltimore, but what's interesting is there seems to be a couple different, as we talked about today, patterns of damage that can occur, myelin-centric, axon-centric, or both. And so in the acute setting, I think people can have the exact same symptoms. So if it's your optic nerve, whether it's myelin or axons being damaged, you have blurred or loss of vision. But over the long run, the recovery is probably mandated by that % damage. And the more myelin damage you have with intact axons, the better your recovery. The more axonal damage you have, the more limited recovery is a guess that we have. It's unproven, but some data to support it. And so in the acute setting, we can't tell the difference right now between the two. And so my guess is what dictates why some people have this nice recovery over X period of time and some people still linger is what was actually getting damaged in the two. That's my best guess. Rate of intervention, we have some preliminary data on that the sooner people get to appropriate therapy, we put the fire out faster and allow for endogenous repair mechanisms to go in. So we do think time to therapy makes a difference.
Let me just add one thing. Those kind of observations you bring to us are invaluable. You know, if you've kind of stimulated my thought pattern, now I'm thinking, how many of my optic neuritis patients were on the left and how many are on the right? I'm going to go back and look now because when you, it was. No,
all right, all in favor of left,
all
two
left.
years at left. Right.
All right. Okay, so.
Okay.
Okay. I have to go look now.
I have to go look.
You did it to me. See that?
See, we got an outlier. But she's from the southern hemisphere, so it might be. They reverse things. So. Yeah, exactly.
One more falling into the category of an observation for everybody to think about, which is, our family was just impacted by this back in August, and I have another very good friend who was here today who was impacted by it, TM, in December. And I'm struck by the comments that have been made about the fact that this is rare and therefore, pharmaceutical companies are generally not as interested in investing, especially if you're talking $1 to $3 billion. And a lot of times this gets to be a numbers game. So I would like to suggest that we start tracking how much all of us have spent and how much the insurance companies have spent and how much Medicare has spent. Because just in our particular case, over 3 months, we're estimating that by the time you've done everything, there's probably somewhere around $300,000 that has gone into that. Now you multiply that number times 35,000 people, and all of a sudden you're talking about close to $10 billion. That's a number that would probably get the federal government's attention, that would probably get a lot of people's attention, that 35,000 patients wouldn't.
And it's a great point. I agree with you in substance. I'll point out the one flaw with the argument, and that is it's using logic to get there. And when it comes to funding priorities at a national level, I've yet to see logic and reason actually get us across the line. I agree with you on face, but you raise a great point about the huge investment. You're calculating dollars investment. One of the things that often doesn't go into that calculation is how many of our loved ones aren't working so they can care for somebody who's going through it. So lost productivity. There's no dollar figure to put on the emotional toll that happens to a family. And so this is a huge public health issue from start to finish. Early recognition, early treatment, chronic management, and what do we do as a society to address these things? And so it's a very, very valid very valid point. To my knowledge, there has not been a single pharmacoeconomic study for TM, ADEM, or NMO. And what that means is an economist sits down and does that calculation. What are the true dollars out of the economy spent because of this illness? It'd be an interesting dollar figure to come up with. You're probably underestimating. It's probably beyond 10 billion.
Okay, so if I could quickly I can't speak now because I'm all nervous. All right, but we have been through, and I think a lot of us have been through like diagnoses that have changed. Started with ADEM when we were first in the hospital we've even had a Parkinson's diagnosis and everything else, and he did fine on the meds, everything else in between. But as y'all are talking about developing research, and I totally understand this needs to be researched more for financial reasons, also too because there's a limited patient base, but are y'all formulating or creating models of decision trees or something for, I mean, I really appreciate, Dr. Pardo, you had the slides showing the evolution of the diseases coming apart, being part of MS, coming out of MS. Is that happening because we now have a transverse myelitis, but as we sit here, he doesn't have one lesion, he has multiple lesions. So now we're like, oh, wait. So we're having to be the sleuth, which is fine. I mean, I think all of us become advocates for ourselves here, whether we're the caretaker spouse or the patient. But is that something that y'all are formulating or creating, since y'all are our front line here in the United States, to help doctors who don't know, or as we've had neurologists refund us because we're too complicated? Are y'all creating those decision trees or something for diagnoses to actually come forth? That way we can make progress or start the healing process or actually just understand, because the emotional side effects of just not knowing or not having a plan is equally taxing as the physical side effects and the darkness that we're in.
Yeah, so actually there has been a lot of work on that issues. I believe it was 2004, the meeting that we have in Baltimore was 2004? 2001. In 2001, we have exactly one of these symposium in Baltimore. And in that symposium, we basically got all neurologists who have been somewhat related with transient myelitis. And we sat down for a couple of days and outlined diagnostic criteria for transient myelitis. And this is evolving. I mean, those criteria that were outlined in 2001 have been changing over the past few years. Probably in the near future, we are going to generate another set of criteria. The information that you are providing in the registries are extremely important, and the initiative that the TMA has for establishing this web-based registry is extremely valuable for us, because that will give us more elements that we are going to use for our research, and particularly for defining algorithm. That's the word that we use in medicine to establish differential diagnosis of disease. It is interesting. Last year we did an experiment in our transient myelitis center because we were very focused on differentiating transient myelitis versus vascular myelopathies, and we gathered all of the data from the patient that we have studied at Hopkins, trying to generate an algorithm. And actually, we were a little bit frustrated because even with the information that we got, a lot of sophisticated imaging techniques, we were not able to outline clearly an algorithm that differentiates very well the two syndromes. So it's still work in progress, but again, the contribution that all of you are going to provide with all of these registries and clinical information are going to be very valuable for that.
One thing I'd like to add to that is education of ER docs, because they are very ignorant, especially when it comes to rare neurological diseases, and they are literally on the front lines of this.
Yeah, it's a huge issue, and from an advocacy point of view, I have a bias on this, and I'll tell you my bias. I actually do not need for any ER physician in the world to have heard the term transverse myelitis to do their job. I actually don't need it. I need them to be able to recognize a spinal cord that isn't working. They don't have to know why it's not working. They don't have to know, you could have been stabbed in the back, fallen off a bike, or transverse myelitis. The mechanism of injury, they're in the front line. The real issue is getting them to recognize spinal cord. We have so many patients who go in with urinary retention, and a catheter gets placed, and a liter of urine comes out, and they go home with a diagnosis of urinary tract infection. In the history of mankind, a urinary tract infection has never caused retention of a liter of urine. I can't find a line in a textbook that says this, and yet that's the diagnosis a lot of my patients get. I still can't figure it out. So every time, Mike or myself or Carlos or Audrey or Maureen or anyone from our groups are out lecturing to groups, we try to put this in and try and spread the word on education, because you're right, the ER physicians, pediatricians, internists. Those are the three people we call first when we're having an acute new issue that we don't know what the heck it is. So there's really no value on the recognition side by getting our neurologists that much better, although it's important because even neurologists miss things too. We need those lines just to recognize something's wrong in the spinal cord and then get help. It's an issue. But as you're talking about in your community, I would actually not focus on the rare disease side of it. Because when you do, what goes through people's mind is, well, if it's rare, I'm not going to see too much of it. But they could see spinal cord problems for lots of reasons. And so we want to dovetail into it. This is where riding the coattails of bigger diseases like MS is useful. Because if they can recognize it in an MS patient, they can recognize it in us. So having a broader umbrella is worthwhile for the recognition side. But it's a huge problem.
And one of my patients made a laminated card, the name of the diagnosis, the name of her doctor, phone number, the common symptoms, and just hands it to the ER doctor and says, okay, my symptom is this. Here's the information that you'll need to know. They go back, they can Google it, do whatever they need, and it gives them a little brief explanation.
Yeah.
So,
And
yeah.
And we have a couple patients, especially on the neuromyelitis optica side, where there can be recurrent events, who actually carry a letter from me from the clinic saying, this patient has neuromyelitis optica. If they present with one of these things, please contact the following number. And they literally just take it out because they've had bad experiences more than once. And so whatever you have to do to protect yourself is important. So, what's a timely fashion for treatment in the acute setting? The sooner, the better.
Well, TM is my fifth diagnosis, that's all.
Fifth, and that's probably about average, I guess, actually. Most people, you're probably the soonest in the room, because it sounds like from symptoms to TM in 13 hours, that may be a record. Most people move through, they'll hear Guillain-Barré in the ER, urinary tract infection, pinched nerve. Pinched nerve is my favorite. There's a pinched nerve. What was it? West Nile. West Nile.
I hate Lyme disease.
Yeah. TM's not the first, usually. So, again, it's trying to move to spinal cord first, I think, and then the etiology second. But it's not easy. But the sooner we can close that gap between recognition and treatment, the better we're going to be. Yeah.
I might have been treated quickly, but he also said, oh, we've finished treating you with your 5 doses, and now you can go home, and we'll see you in a year. So one of the things I've been talking to some of your staff is I would love to see, again, bring it back up to the next level for spinal cord injury, have an app that I have one for, hey, fat secret for trying to do that weight loss. Why can't we do something similar for, TM, on having your computer say, these are some of my symptoms, these are what I'm looking for to keep track of for my urinary tract, for my bowel, for, how much fitness am I doing? We talked yesterday about how do you feel before you start your exercise? Do your exercise. How do you feel afterwards? How do you feel later in the day? How do you feel tomorrow? And keep doing that so you have measurable goals. You have something that is quick and easy, you just tap it. If you want to go back in and give more information, you can go to your PC and add in all that layer. Maybe that something feeds into a registry, or something that you can print out to your PCP, your primary care physician, or your specialist. Yeah. Oh, okay.
Patients Like Me allows you to track all of your symptoms and actually charts it.
Does it do like bowel and urinary? Oh, okay.
It will link you
Oh, no, that's great. Okay. Okay. Yeah, and if we could have something like that at a higher level, I'll take a look at that one and see, but that would be great.
Okay, we are winding down this last question. No pressure.
Hi, I'm Nancy Noonan. My daughter-in-law Cynthia came down with transverse myelitis 6 years ago. And actually, this is the third symposium I've been to, and I just think you're all fantastic, and thank you. I remember that Dr. Kerr, and by the way, he used to be the head of the Johns Hopkins transverse myelitis department, was supposed to do a stem cell transplant surgery about, was it 4 years ago? What happened?
Well, there's lots that happened. Back when I started in the lab, I used to follow him around in clinic, and he used to tell people, okay, next spring, we're going to have the stem cell trial. And that spring would roll around, this fall, and that would perpetuate every 6 months. And the problem is it's hard. It's really hard to launch a stem cell trial. Stem cells had never been approved for human use in the central nervous system until 2010. And that took an act of God, I think, to get the FDA to agree to that. But since then, there have been 4 human stem cell trials in just 3 years. So it's finally moving. I think companies are seeing the profit in this. I think academics are seeing a light at the end of the tunnel. And I think there's a patient demand, and I think the combination is going to ultimately prove beneficial.
But is he still planning on doing that?
No, he is now in a different area of research. He's no longer studying transverse myelitis and stem cells.
And Barbara, I don't know if you have a comment on that, just from your view, the state of the state to actually moving from what's happening at a bench into humans. And we get this question all the time about timelines for different things. So on the mesenchymal stem cell side, or?
It's still, in terms of CNS, it's still much more going on at the bench than actually the clinical trials. There is much more on the application of mesenchymal stem cells, obviously for mesenchymal purposes, such as arthritis or other purposes. But there are some clinical trials that are actually for MS that are on mesenchymal stem cells right now. And if you go to clinicaltrials.gov.com, these trials are listed there.
Okay, well, I want to thank the panel. You guys are off the hook. Thank you for everything.